In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for Extract 1.
Extract 1. Questions 1 to 12. You will hear a pulmonologist consulting with a patient named David Thompson. For questions 1 to 12, fill in the blanks in the notes with a word or brief phrase. You now have 30 seconds to review the notes.
Good morning, Mr. Thompson. I've reviewed your notes and see you've been experiencing some issues lately. Could you describe what's been happening in your own words?
Sure, it's a mix of things, really. First, I've been feeling constantly tired. I just don't have the energy I used to. I've also developed this dry cough. It's persistent, but I'm not coughing up anything like phlegm or blood. What's really concerning is the shortness of breath. It's bad. I get winded even when I'm just getting dressed or climbing a few steps. I've also lost quite a bit of weight, though it's been slow in progression, so I didn't notice I had. Over 6 months, I've dropped around 10 kilos, but I haven't been dieting. I still love my food.
I see. Have you noticed any other unusual symptoms?
Yes, my fingertips are enlarged or rounded, and my toes are the same. My nails have become pliable. They're not as firm as they used to be. Look, you can see for yourself.
Yes, I can see what you mean. Let's talk a bit about your background. What kind of work do you do?
I spent about 20 years as a farm worker, but it was tough, physically demanding work. I couldn't manage it anymore, so for the past couple of years, I've been a nighttime security officer at a DIY warehouse. It's a lot less strenuous.
That sounds like a big change. Do you find it easier on your body?
Definitely. I just don't have the stamina for physically taxing work anymore. I've even had to give up golf. I can't handle it. I spend my free time taking care of my pigeons. I've been into that since I was a teenager.
That's an interesting hobby. Now, looking at your medical history, it says here you were diagnosed with hypertension last year and are currently taking a beta blocker.
Yes, my GP prescribed it. He also mentioned hearing crackles in my chest during a checkup for my breathing problems. I can't hear them, but he could with his stethoscope.
I see. Is there any family history of respiratory or lung issues or other serious illnesses?
Not that I know of. My mom was always healthy, but my dad had eczema as an adult. I remember he had red patches on his face and hands, but there were no lung problems that I know of.
Right. Regarding your past tests, you had an echocardiogram about 6 months ago and a chest x-ray 4 weeks back.
That's right. The echocardiogram was to check my heart, and the chest x-ray seemed fine as far as I know.
Understood. Now, I know hospitals can be daunting, but I'd like to recommend some additional tests.
Oh, okay.
First, an arterial blood gas test. This will help us understand how well your lungs are functioning, how effectively they're delivering oxygen to your blood, and removing carbon dioxide.
I see.
I'll also arrange a CT scan, which will provide more detailed insights compared to the chest x-ray. Depending on what these tests reveal, I might prescribe a course of corticosteroids, starting with a low dose. We'll evaluate further once we have the results.
Extract 2. Questions 13 to 24. You will hear an ophthalmologist speaking with a patient named Emma Carter, who recently had eye surgery. For questions 13 to 24, fill in the blanks in the notes using a word or short phrase. You now have 30 seconds to review the notes.
I have your records here, Mrs. Carter, but since this is our first meeting, could you tell me a bit about your vision and the treatments you've undergone over the years? For example, did you wear glasses when you were a child?
Yes, I did. I've been wearing glasses since I was about 7. My parents noticed I held books very close to my face while reading, so they took me to an optometrist. That's when I was diagnosed with astigmatism.
I see. Was it myopic, meaning short-sighted rather than hyperopic?
Yes, that's correct. I'm short-sighted.
That makes sense. Some people can have mixed astigmatism where one eye is nearsighted and the other is farsighted.
Oh no, that's not my case. Along with the astigmatism, as you've probably noticed, I have a flickering in my eyes. I don't notice it myself, but others often point it out. I think it's called nystagmus. Because of this, they decided to use general anesthesia for my surgery instead of a local one.
Understood. Were you ever told what might have caused these conditions?
Yes, I was informed that my poor eyesight is likely due to insufficient pigmentation in my eyes. However, apart from needing glasses, my vision hasn't caused me many difficulties overall. Driving is an exception, though it's simply not an option for me. I'd never pass the vision test for a driver's license. It also takes me longer to focus, so being behind the wheel wouldn't be safe.
That's completely understandable.
Sports have also been a challenge, particularly ones like tennis. I've always struggled to judge distances accurately, which made it frustrating during my teenage years, but I haven't really missed playing since then. Fortunately, my sight hasn't caused me issues at work. I'm a hotel receptionist, and I've always been able to read computer screens without trouble.
That's good to hear. And I assume you've been getting your eyes checked regularly.
Yes, every couple of years. My prescription has changed a little over time, but not significantly. I do rely on reading glasses now, though. About 3 years ago, I was told a cataract was forming in my right eye. They didn't operate immediately, but this February, I finally had the surgery, and it went smoothly.
That's great news. Were you happy with the outcome?
Yes, absolutely, I was thrilled. If only all our aging parts could be fixed so easily. But at my routine checkup a few weeks after the surgery, they mentioned there was some clouding or opacity, as they called it, in the capsule containing the new lens. It was a bit disappointing. They said they could clear it with a laser if it becomes a real issue, but my nystagmus makes that a tricky procedure. I was also told that cataract surgery increases the risk of retinal detachment, but thankfully there was no sign of that in my case. They scheduled a follow-up appointment for 6 months later, but advised me to get in touch if I noticed any concerns.
And is that why you've come in today?
Yes, I've started noticing 2 things that worry me. First, I've seen more eye floaters than usual. I'm not sure if that's a serious problem. More troubling, though, is that I'm much more sensitive to bright light or glare than before. I'd like to hear your opinion on these issues.
All right, let's start by taking a closer look at your eyes.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen.
Now look at question 25. You hear a nurse briefing a colleague at the end of her shift. Now read the question.
All right, the next patient to discuss is Susie Williams in bed 3. She was admitted due to chest pain to rule out a myocardial infarction. So far, her EKG results are normal, and the initial cardiac enzymes and troponins are negative. When she was admitted, her blood pressure was slightly high, around 182/95, but she was given losartan, and by 6 p.m. it had dropped to 142/82. She was also dehydrated, so we started IV fluids, D5 half-normal saline, running at 125 milliliters per hour. This can continue until midnight, and then it should be disconnected. She's scheduled for a stress test tomorrow, along with additional enzyme tests. Is that clear?
Question 26. You listen to a segment of a hospital management meeting where an issue is being addressed. Now review the question.
Now, if we compare ourselves to other hospitals of the same size in other regions, we're actually recording lower rates of staff turnover. That's just as well given the challenges filling vacant positions across the sector. Where we do compare unfavorably is in the number of days lost to sick leave. That's making it hard to maintain full cover on the wards, and we all know the cost of that. As a matter of urgency, then HR are looking into the worst affected areas to understand the behind it and to see if there's anything we can do to help and support the staff involved.
Question 27. You listen to a GP and a practice nurse talking about a vaccination program. Now review the question.
It's almost that time of year again when we need to start getting ready for the flu vaccination program.
Yes, we usually kick it off at the beginning of next month, right?
That's correct. Remember last year we rented a local hall and vaccinated as many people as we could in a single afternoon.
Yes, I'd only just started working here at that point. It was a busy couple of hours, but I think it went quite smoothly overall, don't you?
Absolutely, but with all the recent publicity about the benefits of getting vaccinated, I expect we'll have a lot more people showing up this year.
In that case, we should consider hiring an agency nurse to help out.
Good idea. Let's run it by the practice manager. She might have some additional suggestions as well.
Question 28. You overhear two hospital nurses talking about a patient's assessment on their ward. Now review the question.
The bed manager just called. He needs us to free up 3 beds on the ward, today.
It never ends, does it? Let's see what we can manage. Nobody's ready for discharge yet, but we could follow up on referrals for Mr. Patterson to the community hospital for rehab. Where are his notes?
Yes, but has he even had his assessment yet?
Most of the team was away at that conference yesterday and the day before. I think he's probably been overlooked.
But Dr. Patel has already declared him medically stable and signed off, so he should be the next one to transfer.
Then let's get him moved as soon as possible before the spot goes to someone else.
Question 28. You listen to the opening of a training session for dental students. Now review the question.
This is session number 4, which is going to include, again, impression taking. We've created the crown impression of tooth number 30. We also took care of an inlay preparation. So today we're going to stay on that side with our impression taking. We're going to make a duplicate of what we've already done. And our attention to detail is now going up another notch. When I take an impression of a tooth that I've created in the mouth, I naturally have to take care of the saliva, the blood, the gum tissue. We're not going to cover all that today. You'll hit that next semester. What we are going to cover are the dynamics of your impression, the margins, the proximal contacts, the bite, and the occlusion. We're going to capture all that in one impression.
Question 30. You overhear two nurses talking about the care of a patient with a kidney infection. Now read the question.
I can't find the results of Mr. Johnson's last blood test for creatinine levels. Were you the one who did it?
No, that wasn't me. Let's have a look. Ah, here it is. The test was done 4 hours ago, and the results show a level of 38, so it's still significantly below normal. We should do another test when he wakes up, as it might have changed. But he's not a fan of needles. I had a tough time last night convincing him it was necessary. He's not the easiest patient to deal with if you're up for giving it a try.
All right, I suppose it's my turn now.
Extract 1. Questions 31 to 36. You listen to a presentation by Dr. Emily Carter, a geriatrician, discussing end-of-life care for individuals with dementia. You now have 90 seconds to review questions 31 to 36.
My name is Dr. Emily Carter, and I'm a geriatrician specializing in palliative care. Today, I'll be discussing an increasingly significant issue: end-of-life care for dementia patients. Caring for dementia patients presents unique challenges. Dementia is a terminal illness and the third leading cause of death in Australia. However, unlike other terminal conditions, dementia has an unpredictable progression, and there are often complex issues surrounding patients' mental capacity, decision-making, and communication. Despite their equal need for palliative care services, dementia patients don't always align with the traditional model of such care. Families frequently experience distress, feeling unable to ensure their loved one's wishes are respected, or simply unaware of what their loved one would have wanted due to the lack of early discussions. This underscores the need for well-funded, patient-centered palliative dementia care that is accessible when and where it's required. I work extensively with Dementia Australia, an organization dedicated to representing the needs of Australians living with various forms of dementia, along with their families and caregivers. The organization also advocates for dementia-related issues and funds research. Recognizing the growing urgency, Dementia Australia decided to investigate end-of-life care for dementia patients from both the consumer and healthcare professional perspectives. This was a timely initiative, as we have plenty of anecdotal evidence but lack comprehensive data to understand the failures within the system. That said, the situation isn't entirely bleak. While there are significant challenges, there are also inspiring examples of how effective palliative care can profoundly improve lives. When managed well, individuals with dementia can approach the end of life peacefully and with dignity. To gain deeper insights, Dementia Australia commissioned a nationwide survey examining end-of-life care issues for dementia patients. The survey included responses from both healthcare professionals, doctors, nurses, and others working with dementia patients and family caregivers. Over 1,000 responses poured in, underscoring the high level of interest. What did the findings reveal? The initial results highlighted a glaring disconnect between the perceptions of care professionals and family member carers regarding access to end-of-life care. For example, 58% of family carers reported not having access to palliative care specialists, and 68% lacked access to hospice services. Yet, 3/4 of healthcare professionals believed that dementia patients in their area had access to palliative care. This raises the question, are patients and carers simply unaware of available services? Another troubling finding was the lack of knowledge among healthcare professionals about the legal aspects of end-of-life care. Some professionals hesitate to use pain relief medications like morphine due to concerns about potentially hastening death. However, access to adequate pain relief is considered a fundamental human right, even if it might inadvertently shorten life. The survey revealed that 27% of healthcare professionals were uncertain or did not believe that patients have a legal right to effective pain management, even if it hastens death. Alarmingly, a quarter of former family carers felt that pain was not adequately managed in end-of-life care. This lack of knowledge extends beyond pain relief. The statistics regarding treatment refusal were particularly concerning. Nearly one-third of healthcare professionals were unaware that patients have the right to refuse food and hydration, and 10% were unaware that patients could refuse antibiotics during end-of-life care. How can we achieve consumer-directed care if the professionals themselves lack awareness? There's an urgent need for better education and training on patients' legal rights, yet over a third of healthcare professionals reported never receiving such training. End-of-life care planning is clearly essential. Discussing and documenting patients' preferences is the best way to reduce the burden on carers and ensure patients' wishes are respected. Advanced care planning serves as a safeguard, protecting patients if they lose their capacity to make decisions. While patients often assume their loved ones will act in their best interests, evidence shows that family members frequently struggle to make accurate decisions about complex issues like infection control and hydration. By planning in advance, we can avoid placing unnecessary stress on carers and ensure that patients receive the dignified care they deserve.
Extract 2. Questions 37 to 42. You hear a hospital doctor, Dr. Thomas White, delivering a presentation about his research on the topic of staff-patient communication. You now have 90 seconds to read questions 37 to 42.
Good morning. My name is Dr. White, and today I'll be sharing some research I've conducted on a key issue affecting all healthcare professionals: staff-patient communication. First, let me reassure you that, based on feedback, patients generally seem positive about the way information is communicated to them. However, I decided to dive deeper into this subject after an experience I had as an observer in a hospital. During that time, I saw firsthand how misunderstandings can arise when healthcare professionals believe they have communicated clearly with a patient, only to realize that the message wasn't received as intended. While I'm fortunate that my team has received very few complaints, the potential for miscommunication is definitely there. Let's begin by examining a typical hospital admission and the first communication a patient receives about the procedures they'll undergo. Upon admission, patients fill out necessary forms, and various staff members discuss their treatment plans with them, which is intended to ease anxiety. However, from the perspective of some patients, this communication can feel overwhelming, especially when they're not in the best physical or mental state. Therefore, it's crucial to ensure that patients fully understand what is being communicated to them. At this point, let me share a hypothetical case that I often use. It highlights the possible consequences of poor communication. A man in his 80s is admitted to the hospital due to severe back pain. Upon examination, it's discovered that his cancer has spread, and the prognosis is poor. His condition is further complicated by depression, and he refuses to eat. A feeding tube is inserted, which the patient agrees to, though his family has concerns. The doctor updates the family, assuming they are aware of the severity of the patient's condition, but in reality, no such information has been shared with them. This is an extreme case, but unfortunately, not an uncommon scenario. To understand what inpatients truly think about the care they're receiving, we conducted a survey to gather their views on communication. The survey targeted patients' opinions on the effectiveness of the communication during their hospital stay, comparing their expectations before admission with their actual experience. We also included questions about their willingness to return to the hospital for treatment, based on their experience. The survey was filled out by patients, and the data was processed with the help of medical students. The survey revealed some valuable insights about communication, both positive and negative. It's clear that in a hospital setting, staff are handling sensitive and confidential information that must be communicated in private. This can be challenging in a busy hospital environment, but we received positive feedback in this area. Additionally, staff were praised for communicating in a way that respected patients' dignity. However, the most common complaint was the use of medical jargon and complex terms when explaining diagnoses and procedures, which left some patients feeling confused. On a positive note, patients expressed satisfaction with the information provided about follow-up treatment after discharge. An interesting pattern emerged regarding the care provided by nurses, which I found particularly intriguing. I had assumed that having multiple nurses attend to a patient was beneficial, as it ensures there are enough staff to cover shifts and meet patients' needs. However, patients reported feeling their recovery was faster when they interacted with a smaller number of nurses, essentially when they were surrounded by familiar faces. While these findings are not conclusive and more research is needed, it definitely gives us something to think about.